I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Today's program focuses on hospice care. Hospice, by definition, is a home providing for the sick, particularly the terminally ill. We'll explore this, try to go over some details about it, and really educate us all about hospice care. And we have some wonderful guests here tonight. My guests include Dr. Tom Florenza, the Director of the Visiting Nurse Service of New York, Hospice Care, Hospice, and Director of Oncology at Richmond University Medical Center on Staten Island. Roxanne Salgado, who's a registered nurse and the Hospice Team Manager, thank you, and Melissa Lanza, who's a family nurse practitioner who's in practice on Staten Island. Thank you all for coming and really trying to educate us. We've done some programs on oncology recently, and many of my patients as a neurologist ask me questions about hospice care. And there's so many things that I think there's true information, misinformation out there. And I said, let's use this forum to try to figure out what's going on. So tell us a little bit, and I'll start with you, Tom. Tell me a little bit, what is hospice?
Hospice is for the living. Now, that may sound contradictory because everyone associates it with dying, but it's not. Once you have a disease, and it doesn't have to be cancer, it could be heart, lung, renal disease, that you're at the point where active treatment is not wanted or indicated. Not wanted by the patient, the family, not medically indicated, and not wanted by the patient or family. Then you may be a candidate for hospice. So what hospice does is it accepts that fact that you're at this point in your disease, in your life, and we want to make whatever is remaining between you and when you leave this life as best as it can be. So really it's a focus on living and getting you support with the team, the core team, which is a priest or a pastoral care person, a social worker, a volunteer who can go in and relieve your family if you have to go out and there's to be someone caring for the patient, the nurse, and the physician. This is our core team. And there's an outside row of people who can be called in for subspecialty work. If you need physical therapy, let's say, for a particular reason, and you're at home. Hospice takes place wherever you are. Nursing home, your own home, in a hospital inpatient unit.
Even in assisted living facility.
Even in assisted living. So it's wherever you are, we go to you.
So Roxanne, help me a little bit. As a neurologist, I have people who have illnesses that are incurable. I have people who I see with ALS or Lou Gehrig's disease, certain muscle diseases, tumors. How would I know when to call hospice? Or does it have to be from a doctor? Does it have to be from a healthcare professional? Who calls hospice?
Well, hospice is really a compassionate caring model. So when you're going to call hospice, it's usually at a point in time where your provider says there's usually no more treatment involved. You're at a point where your disease, if your disease continues to progress normally, then within 6 months or so, you may no longer be living with us at this time. So we want to present a person with hospice prior to them having end-of-life symptoms where they're not able to have a good quality of life. Because once you're on hospice, you're able to be presented with pain management specialties as well as other physical therapy and treatments that can help you increase your quality of life. And we provide that on a daily basis, either in the home setting or in an inpatient setting.
Do you think hospice is utilized to the fullest degree? And what I'm getting at is I have patients who are very elderly, very frail, and I don't know how long they're going to live, of course, but they have numerous illnesses that we take care of. Do those people, do they fall into the category of where hospice might help them? How would I know? And again, talking as a physician, neurologist, and also as a layperson, how would I know when they meet that threshold?
Well, there are some specific criteria that is spelled out by the government, CMS, of course, that tells you exactly when a person qualifies for hospice, because you have to qualify. It's not just you and me can't just say, hey, well, I'd like to be on the hospice program. You do need to qualify. There's a provider. The provider says, can state that if your disease takes its normal course within 6 months, then you will no longer be with us. But then there are times that the disease process continues on for longer than 6 months. And some people even graduate off of hospice and are able to continue treatment onto other programs.
So Melissa, help me a little bit. I know you're very spiritual. I know you have a wonderful practice out here. How do you decide when you have a patient who comes to you who has an illness, a very severe illness, and you don't think they're going to survive, their life expectancy is not more than 6 months, and we don't know. As Roxanne said, there's no guarantees in anything. How do you decide where and how do you counsel the family about determining if hospice would be appropriate?
Well, I'm very honest with the family. When they get the diagnosis, I'm very honest, and I allow them to, again, I put the options on the table. I allow them to make their decisions, and they're thankful when I do refer them to hospice. They're thankful, but they wind up still coming to me with the spiritual support. I wind up still emotionally being there, spiritually being there for them, and they have found that these books, these 3 different books, the book for journaling, this other book helps also. It helps with the patient to prepare because when you know that you're dying, there's again there's all different stages of grief, and the person goes through all different phases. So this book also helps the patient, it helps the family, it helps the caregivers, and so they have this book as a guide, and this is another book, In My Presence, and Experience God's Presence, and then this journal. And the family has told me that this has really helped them, and it's helped patients to transition and to be more accepting of their state and of their condition. And it helps them, they wind up dying with dignity and having comfort, and their pain is addressed, all the different needs that they have, the psychosocial, the spiritual needs, and the team helps as well. It's not just these books. Again, with hospice, you have the whole team. You have the doctor, the nurses, the social workers. You have everybody involved.
We talked about the team, and I want to take it from a theoretical group that's helping and everything else to brass tacks. I'm out there and I'm listening. I'm saying, there's somebody in my family who might need hospice care. What is it, and I really want, what are the details? What could be provided? What kind of things, and again, I'm not even talking about CMS, insurance, whatever. What do we do on Staten Island to help this family get through this area, get through this time? And as I said, really more, and I'm looking for details. Does someone go to the house every day? Does someone help with preparing food for a family or get Meals on Wheels or something? Tell me a little bit about the details of how this would help somebody.
Well, some of the services that we provide in the home are nursing services, and skilled nursing services at that. So if a person has a wound, instead of having to go to a wound clinic to get the wound addressed, then the nurse can come to the home. They can come to the home daily, weekly, at whatever frequency is provided or is ordered by the doctor to dress the wound. We also provide you with your supplies and medications. Sometimes with the stigma to opioid medications, many providers nowadays are honestly kind of scared to prescribe high doses of pain medicine, especially with a person that has terminal illness. The pain can get very much out of control. And we're used to prescribing, let's say, 10 or 15 milligrams of a pain medicine, and we think that's okay, but then this person here is saying, well, that's not enough. I need 10 or 15 milligrams every 30 to 45 minutes. So what do you do then? Then you have to have a specialist that helps to provide this pain management at higher levels, at safer levels for this individual, and providing guidance for them, as well as home health aid hours. When you're in the dying process, you're not able to perform activities of daily living for yourself, cooking your meals, getting dressed. I mean, even simple tasks such as brushing your teeth can make you very, very tired. So we provide you with some home health aid hours. A home health aide can come in and get you dressed for the day. They can take you out, for a walk if you're able to dress yourself and you're just not able to get out there safely without falling. You can have a home health aide assist you with that. We also have pastoral care, where we can have a spiritual care counselor, or even if you're of other faiths, we have pastors or rabbis come in that can help you to transition your faith and to keep you grounded even though you're going through a tough time. And sometimes I realize a lot of our patients, even though the doctors come on and say that they're going to pass in 60 to 30 days or 6 months, some of them last much longer because there's less stress in their life at that point in time. We're able to focus really on having a good quality of life and compassionate care, and sometimes taking all the other stressors out, it causes the person to actually get better. And then they get off of the program and now they're on to another program where they're able to get treatment and continue treatment.
Tom, tell me, we spoke before we went on the air, and I said I'd like to bring a positive note to hospice. I don't want to have sad shows, even though life has ups and downs and we all die. The question that comes, and you said to me, there's a lot of positivity to talk about. And I'd love you to bring this to our audience. And Roxanne just did, basically saying people graduate, people sometimes get better, you take the stress out of the system. From a physician's point of view and as director of the hospice, of the Visiting Nurse Service of New York's hospice out here, tell me a little bit about your experience with how it affects the actual family, the patient, and back to more telling us what's going on on a day-to-day basis when you see your patients. Even some examples, I think would help us compared to saying, well, people get better or people have less stress. What kind of things do you see? And maybe even give me an example of a family and how you've really helped them.
Well, it's a team approach, and each patient is discussed once a week. So everyone, whether they visited the patient or not, can participate in this. So you may get a different opinion. A pastoral care person hearing you reporting about difficulty breathing may say, yes, but I saw him 2 weeks ago, and he really said that he was having a lot of trouble getting in touch with God, with his inner soul. And I began to speak to him about that, and this may be a reaction to that. It's very interesting because when you start looking at what we call the whole person, and really in hospice, it's the patient and the family that is our patient. So we're treating the unit. And different interactions within the family. We have a social worker who may see something completely different than a medical professional would or a nurse would. And we learn from these other professionals how to look at the problems differently. Now, this idea of graduating, everyone is reevaluated every 2 months initially, and then periodically after that. And if you're improving, but you still need the services of the hospice, and your disease course is not, you're not really, you're going out on your own, you're driving, then you really couldn't be on hospice. But you can improve. I mean, certainly it's been shown that by little supports in the home, overcoming some obstacles as simply as removing some rugs, showing person they can do things, they improve and they feel better about themselves. So once these seeming barriers are removed, the patient can start living. That's why I initially said hospice is about learning how to live as best as you can with the circumstances that you're in. So, and it's wonderful to see patients progress. The difficulty we have with hospice in the United States is that patients are not referred early enough. So when people get to the point where they don't want to keep doing whatever procedure they're doing for whatever reason, and hospice can show them that there is something else to life except for going for chemotherapy or going for radiation if it's not working. I mean, I'm not discouraging people from stopping treatment. I don't want them to stop treatment.
Right, you're
But
an oncologist.
I'm an oncologist.
That's what
I want,
treat
I
patients.
want to be able to cure somebody, but unfortunately, it gets to a point sometimes where it's just not working, and family members say, "Please do something else. Please do something else." And sometimes the patient gets lost in that conversation. Sometimes the family does, and you really have to listen. If the patient says, "I don't want to do this," what the physician, the clinician in that situation needs to know is that I do have an option. See, sometimes people, they keep doing things just to keep doing something. But if the family or the patient is giving you these vibes, we've had enough of this. We understand that he's not going to live, or my mother's going to die from this. Let's just stop. He said, well, I don't have to stop. I can give you hospice. And this is how we use it, and it's wonderful. I mean, patients actually have been shown to live longer in that type of situation than if you continue the treatment.
Roxanne, you mentioned before, and I think a statistic of someone who works in a hospital and has a private practice and is around in the community, and I have patients who have been on hospice. Sad to say, as a referrer to hospice, and I'm sure Melissa might echo this too, is that people are on hospice for way too short a period of time compared to what they could be. I think you mentioned to me before it's a matter of weeks or days that people are on hospice.
Well,
What's the average time?
The average time is usually about 8 to 10 days on hospice. Well, in Staten Island, we've actually have a longer time in Staten Island, but collectively in the tri-state area, it's about 8 to 10 days, and it's really not beneficial for a person.
So 8 to 10 days, I refer someone to hospice, Dr. Lanza, your group, all evaluate the patient. The patient will only be on hospice for a week, a little more than a week.
Well,
in some settings. Does that tell you that they're probably not being referred early enough?
I was just going to say that. They're not referring them early enough to take advantage of all of the benefits of the hospice program. Mm-hmm. If they were referred at least, 30 days, they would see that during that 30 days they can have a really great quality of life. We have meetings with the family members where we can have these difficult conversations that families just don't have sometimes, or they don't have the time to have, or make the time rather. No one wants to get everyone together, that be that intermediary to say, well, mom, dad, uncle, aunt, let's all come together and talk about what's going on with our relative here, and they're not going to be with us much longer. Those conversations are sometimes need to take place, but there's no one there to facilitate them. And the hospice team helps that to happen. And during that time, the family members tell us all how great it was for them to be able to say some of the things that were on their mind, but they didn't want it to come out of their mouth because they weren't sure how their family member would receive it. And ask questions that they're unsure about. And this is where we come in. We come into the home and or in any setting. Sometimes some people don't want us to come to their home. We meet in other places. It depends on, we meet them where they are, and that's where a hospice
I know end-of-life issues could be very disheartening for different members of the family, guilt issues, interaction issues, financial issues. Does the hospice team help the family reconcile in this way?
Oh, yes.
In a sense, because if there could be nothing worse for the patient and the person, where one child is angry, and and child, I don't mean in age,
right,
but the son and the daughter are fighting or about different issues. Is a hospice help that type of situation?
Yes.
And I'll even say being married to a wonderful social worker. I know what social work interaction is, how important it is with this type of situation. I'm sure and I know you have wonderful social workers.
Yes, we do. We have some great social workers, and they go through every day. They come to me with all these experiences they have with family members. Maybe the daughter, the sons are not on the same page, and it's usually just education. A lot of the times, maybe one child does not want the parent in hospice. They think that the hospice program is a negative program. And then the other child is saying, well, no, we need the hospice program. And let the hospice tell you what's going on. And it may be that the daughter or sons, calling each other back and forth, and they're talking, but they're not really having the correct conversation. So then we step in and we sit them down and have a conversation and meet the son or daughter where they are, find out what they know about the program, and then we educate them and give them the correct knowledge. And 90% of the time, the family member that was not on board is now like, oh, okay, now I understand why my mother or father or sister, brother needs the program.
I watch television. And surprisingly, I watch things other than our own show.
Really?
So the question comes down to, I see commercials for inpatient, long-term or short-term care, Calvary, hospitals that seem like hospice-type care for a short period of time for people with incurable disorders. Tell me a little bit, when does someone go to a place like Calvary or a hospital? When is hospice at home? How do we decide? How does a family decide? As a physician, I don't even know when to refer people to one or the other. How do we figure it out?
Well, research has shown that, and not even just research, just in general, would you like to die in a hospital or would you like to die peacefully at home? Most people want to die at home, right? So we have, at Visiting Nurse Service of New York, we ensure that we treat you in your home, in a home setting. But we do have inpatient settings for when things get out of hand that we can't handle in the home. Let's say you need a blood transfusion. We can't do a blood transfusion in your home, so we would then take you to our inpatient hospital setting. We would, perform all the lab work and et cetera that needs to be done, and then we perform the procedure. You're able to stabilize, and you can return home. And there's also times when you definitely have to stay inpatient, and you can't return home at all. Let's say if you're on a type of rebreather mask, like a non-rebreather mask, where you need to have high levels of oxygen, and we would have to support you with 20 or 30 tanks in the home. So then you would continue inpatient until we're able to wean you off and take you home. Or let's just say you're having a bleeding problem. There's certain illnesses that continue to bleed, and we have to keep you in hospital. Once we can stabilize you in the home, though, we do like to have our patients if their choice is to stay home, we like to keep them home versus in the hospital.
And you do that at local hospitals? You don't
Yes.
have to have it in any specialized
No,
hospitals?
we contract out to the normal hospitals right down the road from you, your community hospital, the university hospital, depending on what area you're in. And we continue to support you while you're in the hospital. Our nursing staff facilitates your medications as well. And our hospice medical director will continue to order your opioid medications or any other medications for your treatment.
Tom, tell me a little bit about treatment. The idea about active treatment versus not active treatment. So Roxanne said if you have an infection, antibiotics could be given, oxygen, blood. Mm-hmm. How do they define that? Because I think as someone, if it was my family or my patient, my impression of hospice a lot of the times is that you're given pain medicine and basically just supported. So the question is, what can you do? And if someone gets better, that's great. And tell me a little bit about that part. What kind of active treatments do we do?
The treatments on hospice are directed towards alleviating symptoms and treating acute needs. So if someone is having difficulty breathing, they're beyond with advanced COPD.
Tell us what COPD is.
Chronic obstructive pulmonary disease.
Like emphysema, lung disease.
Right, emphysema, lung disease, where the prednisone, the inhalers and so forth are just not working, so they're on hospice. So we have particular ways of addressing the respiratory problems. We give them some low doses of morphine, we give some Ativan to try to calm them down, and sometimes we have to put them in the hospital. So it's not that you don't get treatment on hospice, you get treatments that are particularly directed towards aggressive symptom management. That's basically what we're doing on hospice. And we're doing it in the setting of not going for the cure, not going to get them back running on the track. I mean, there's particular areas in medicine where this is appropriate. What we're doing here is helping them live as best as they can for the rest of their life. So there's no symptom that can't be treated on hospice.
Understood. So Melissa, what do you think? I mean, as a primary care healthcare provider, have we learned? I've learned a lot about hospice, and just want to get a little bit of your feeling as a
Yeah, I
primary
wanted
care
to
provider.
share about some really positive experiences that I've had with hospice, where I've had significant, with families that were very much at odds with one another. I was really impressed at how hospice helped to bring peace to the family, and to the patient was able to forgive family members. The cancer, believe it or not, as bad as cancer is, it was actually a blessing for this family. I mean, the good that came out of it was that the family was really all restored, and the relationships and the healing that went on within the family. And it's terrible to say, why did it have to take a cancer for that to happen? You know, but the positive part of that terrible disease was that this happened, and you know, the patient was, you know, really at peace. And we were saying, you said that hospice is for the living. It is for the living, where it really helped the family members. And then it's also for the dead, because when the patient does die of cancer, they will have a peaceful, happy death. I say that it's a PhD, peaceful, happy death. But it was. I've had many positive experiences where families were really restored and healing occurred, and they had a great experience.
To that point, an aspect of hospice is not emphasized as much as after the person dies, the family gets attention for a year afterwards. So there's some intervention. Usually it starts at 6 months. There's maybe a memorial ceremony, it's
Actually, it starts a little
bereavement
earlier
services.
than that.
It can now, okay.
Yeah, right after 6 weeks, the bereavement counselor, they touch base with the primary person, the primary caregiver, and we, just making sure that there's resources, that they have received resources. If they want to touch base earlier, they can touch base with myself. I have community resources. We have groups that they can go to. We also hold groups in our office and the Visiting Nurse Service New York offices on a weekly basis for our bereaved family members. They can come in and speak with the bereavement counselors, speak with the team. It helps them to be able to talk to the team later on and see, who was meeting with their family members on a daily basis, putting a face to the names, and that helps them to transition on. And
just emphasizing that it's the patient and the family that we're attending to.
And I have to say, as a physician, I've had tremendous benefits to myself, even understanding how patients did, and really the way they coped within their end-of-life issues as families. People with ALS, people with end-stage MS. I mean, you guys have done a wonderful job. This is hospice around the city and the hospitals around the city. And I think it really has given us a tremendous perspective. I want to thank you for all the wonderful work you guys do, and want to make hospice something that we could think about. Hopefully we don't need it in the near future, but if we do, it's at least there. And it's really available on Staten Island and in the outer boroughs and throughout all of New York City through the Visiting Nurse Service. Thank you so much.
You're welcome.
Thank you.
You're welcome.